I would like to start by thanking the Pediatric Trauma Society for allowing me to present this abstract on blunt renal injury. I have no disclosures. The primary aim of this project was to evaluate the impact of a non-operative management protocol for isolated blunt renal injury in children by comparing data from pre and post implementation of a standardized clinical guideline. We retrospectively reviewed the trauma registry at our ACS verified level 1 trauma center. Pediatric patients who were managed non-operatively for isolated blunt renal injuries were identified and subdivided into pre and post protocol cohorts. Any patients that had significant concomitant injuries were excluded from the study. We then analyzed pertinent demographic, injury-specific, and clinical outcome data and compared them between the groups. Here's a schematic of the clinical algorithm. Clinical decision points were identified in an effort to minimize time on bed rest, labs and imaging, placement of urinary catheters, and admission duration. And this was all based on retrospective patient data, literature review, and current best practices. Patient demographics are displayed here in Table 1. There were 48 patients total included in the analyses, 29 in the pre-protocol cohort and 19 in the post. 62.5% of the group was male, and the mean age for all comers was 12 years. There were no statistically significant differences in demographics between the two groups. Figures 1 and 2 show the frequency of mechanism and grade of renal injury in the pre and post cohorts. Most of the renal injuries were grades 3 and 4, but importantly, again, there were no statistically significant differences in terms of mechanism or grade of injury between the pre and post protocol groups. Table 3 shows all of our outcome variables and is really the crux of this study. As you can see, the post-protocol cohort had a length of stay that was nearly 1 day shorter than the pre-implementation group. They also had fewer ICU admissions, fewer labs drawn, decreased catheter usage, decreased follow-up imaging studies, and decreased use of ionizing radiation. There were no catheter-associated UTIs in either group, and there was only one patient who failed non-operative management in the pre-group. In conclusion, the study provides a standardized algorithm for the care of the hemodynamically stable pediatric patient with isolated blunt renal injury. Use of this protocol improved patient care and reduced resource utilization, and therefore would benefit from investigation on a larger multi-center scale. Thank you.